Okay.
Okay, so we'll start off, everybody again, good morning. We'll start off with a prayer in the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Amen.
And in view of the fact that yesterday was the 100th anniversary of the apparition of Our Lady of Fatima, that I will be going tomorrow, which you don't not know, to Lourdes in France as an emergency to replace a physician that cannot go. And so having both those events in this week, we'll say the Hail Mary, 3 of them, to Our Lady. Hail Mary, full of grace, the Lord is with thee. Blessed art thou among women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners now and at the hour of our death. Amen. Hail Mary, full of grace, the Lord is with thee. Blessed are you among women, and blessed is the fruit of your womb, Jesus. Holy Mary, Mother of God, pray for us sinners now and at the hour of our death. Amen. Hail Mary, full of grace, the Lord is with you. Blessed are you among women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners now and at the hour of our death. Amen. Our Lady of Fatima, pray for us. Our Lady of Lourdes, pray for us. Our Lady of Knock, pray for us. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Okay, so the subject for discussion this morning is the patient-physician relationship from the physician's perspective. And I have to tell you that I started medical school in 1959, so you can kind of figure that's a pretty long time ago. And a lot, when I tell you a lot has changed in those years. So some of what I'm going to be giving you is I'm totally familiar with, and some of it is new stuff that I may not be quite as familiar with, but in one way or another did. Maybe not the same way, but did do it. So a little bit of history, and I'm not going to give you much. These slides you can look at, they'll be in your thing, but the point is that medicine has been around since man has been around in some way or another. Mostly it was magic. Mostly it was a belief in something out there, whether they were a monotheistic religion or not, or no theism, that there was something out there that was in control of our life. But one of the interesting things is the oldest surgical procedure was to drill holes in the skull. It's amazing. That is the oldest surgical procedure. Drill holes in the skull to relieve pressure. And I put the pressure in quotation marks because it may be that the patient complained of severe headache. It may be that they actually had fell and something happened. We don't even know what their reasons were. But in fact, people did survive. Sometimes people had more than one burr hole. They're known as burr holes. Okay, they did survive, and it's everywhere you go, all over the world. When you find human fossils, human skeletal bones, you get evidence of this. So it wasn't just in the Middle East. It wasn't just it was all over the Western world and the Eastern world. Okay, so why does this thing say I can't do this? So they're saying something.
Remember the mouse.
It's talking to me. It says I have to sign in.
What?
The computer says I have to sign in. And the procedure was done even in children, in babies, in older individuals, or what was thought to be an older individual at that time. And as I said, they survived. So moving on then, it takes a period of time when the magic gradually disappears, but and maybe even some religious aspect begins to disappear. Okay, and you'll see these. And you'll see that it begins to disappear.
Are they sending off the link?
And there's some ancient Egyptian writings about the kind of medicine and surgical procedures that were done. In the Old Testament, public health was a big issue, public health and hygiene, so religion was still very much involved, but there was the recognition of transmission of infection in some one way or another, leprosy being the big issue, for example. And you read all about how the lepers were segregated from everybody else because, in fact, it was a highly transmissible disease at one time. In the age of Hippocrates, which is what we call somewhat to the beginning of modern medicine, Hippocrates had a philosophy of do no harm, do what is best for the patient, but the physician knows best. And he did a lot of terrific work in his time. You can always look all of those things up. He worked somewhat from the ideas of his own. Aristotle picked up on some of his. And as time went on, the idea of the science began to enter medicine, or more so because it was recognized that it was something wrong in the blood of people who were sick. And so leeches were put on them to bleed them, hopefully to make them better. And you can see from this slide that medicine was in all parts of the world in one way, again, as I said, or another. The first hospital in the Western world, in fact, that we even know about, was in Italy. At that time, there was an interrelationship between the translations that were now found and used in the Arab world, or the Muslim world, whichever way you want to call that, because not all Arabs are Muslims, in the Arab world, the Muslim world, and in the Christian world, merging all of these Jewish world, merging all of these things together. One of the things that in the West, in Europe, medicine was really very, very poor, very, very poor. What was going on in the East and in the Middle East was far in advance of anything that was happening in Western Europe. But gradually that changed, and the information moved on because of these translations. The other thing is that women were really caregivers, no matter which of the worlds you lived in. But Catholic women in the West really took up this role of being the caregiver, providing for the sick. Mostly it was nuns, but it was also not just nuns. Florence Nightingale, you're familiar with her work in nursing, and one of her colleagues was the first person to start the idea of medical records. United States medical schools began in the 1800s. That was then with the development of more and more information and more science and more interest in science. Anesthesia ether was then used for surgery, which then allowed more surgical procedures to be done. I mean, can you imagine cutting somebody's leg off with nothing except alcohol? And that was the way it was done in the Civil War. You know, whatever they had to do was give them lots of alcohol, try to get them drunk, which didn't take away the pain, but did help them forget. It was really, you know, horrific when you think about it. And then with anesthesia and ORs became antisepsis and sepsis in the practice of surgery. The recognition by Semmelweis of the transmission of childbirth fever between doctor and patient, when the doctor never washed his hands between patients. And believe me when I tell you, washing hands today is still an issue, okay? It is very, very hard for so many reasons. It is not always easy to think that as a physician and you're examining patients that you can wash your hands between every patient. Unless there's a sink right there, it's almost impossible to do. Yes, you can use that, but oh God, they're awful on your hands.
Yeah.
It's horrible. Gloves, I love it. Somebody uses gloves to examine the patient, then goes and opens the door, then answers the telephone, then comes back to the patient. I'm like, what was the point of this? Okay. And a lot of that change occurred with AIDS, by the way. Yes, there was some change with Semmelweis and all of his thing, but AIDS really changed the infectious disease and medical world, I might add. Before that, I used to deliver babies with my bare hands sometimes. I didn't wait, but the nurses would go crazy.
No gloves? No gloves?
Well, because the baby was right there. I'd say, well, if you want me to use gloves, where are they? You know?
When they might practice nursing too in my country, no gloves. So
Yeah.
no
Oh, well, I've had to work in that
And
environment.
they use gloves. We use the same gloves and put it in the sterilized.
Right,
machine.
put them in the sterile. I used to do that. We used to do that in Jamaica.
Yeah.
You'd use the same gloves and just put them in the solution and then take them out for the next patient between cases. I mean, it's amazing. And I had to do things like that at Jackson. During the period of time of the Mariel boat lift, we had nothing. When I tell you we didn't have strapes, we didn't have things to wash people off with, we didn't have gloves, we were really stuck with even sterile instruments, you know, because we were in a facility for 4,000 deliveries and we were doing 15,000. And you know, when you're supposed to be only doing 4 and you're doing 15, there's only so much you have. So we had to come up with the changes and procedures and techniques and everything. So, you know, when I go back to washing hands, that's still a problem, okay? And it's still all kinds of, everywhere you go in a hospital facility, in a doctor's office, there are signs everywhere about washing hands, okay? You go into the bathrooms of the supermarkets, same thing. You go into the bathrooms of the restaurants, same thing. Do people always do it? We don't know. So then comes the, as science is developing predominantly now in Germany and in the United States. As science is developing, the Second World War comes along, and of course we're all familiar with the doctors of the Second World War who did all kinds of experiments on patients without consent. Okay, sometimes without anesthesia, without anything, and really did some terrible things to them. So as a result of that, the world, so to speak, all aspects of the world, of the West, began to realize that this is not the way. We've got to come up with other ways. We've got to come up with consent practices. We have to start explaining things to patients. They have a right to know. And in all of this is true. You should not be doing anything to a patient without telling them what you're doing. In Hippocrates' days, for example, and for a long time after that, the doctor knew best. The doctor told the patient what they were going to do. The patient had to accept it. There was no other option. And so it was. But after the war, the Second World War, all of that really changed. So patients were entitled to make decisions and were entitled to share in the decision making. Specialty care began to really grow after the Second World War. And that presented another set of problems in patient care, because now when you have the primary care physician getting a consult, and then the consult comes in, they may not talk to each other. The medical record is by hand, so it may not be clear. Now comes another consult, another consult, another consult. And so many people start getting involved in the patient care. Same thing in the hospital. You have the nurse, besides the specialty consultations, you have different staff coming and going. And it's not always clear who's a nurse, who's a doctor, who's a PA, who's a secretary, who's a ward clerk, who's a social service worker. It was not always clear. How many times in my life I was called nurse? And I never bothered to say, no, I'm not a nurse, I'm a doctor. I didn't, because it was just easier to go with the flow. But
I needed to ask, who are you? Who
yeah,
are you?
well, even when you come in and say,
come to my room and I didn't know.
yeah, and you were told, I mean, that your job, as part of your role, you were told always to introduce yourself to the patient. And then I'll come up to that in a minute, because you would introduce yourself as doctor, but they saw a woman and therefore you were a nurse. You know, and that's okay, no problem. But when they saw a male nurse, especially on an OB ward, for example, that was like, oh my. It was a whole new idea to have a male nurse taking care of OB patients, doing perineal care, for example. Do you know what perineal care is, Patrick? Perineal care is washing off the genital area between patients voiding during the labor, keeping them nice and clean as much as you can and comfortable. And so that was kind of an issue too. But everything started to really undergo major changes, and the patient became compartmentalized, which is not what we really wanted to happen, but it happened. And patients started to, voice their opinion about this, as did we. Teaching facilities, there were many more people involved. Then on top of all of that, we also had these rigid hospital rules. The hospitals were not patient-friendly at all. I mean, the patient comes into the hospital and there's a certain set of visiting hours, and it can only be at that time, and you can't see the patient in between, and the family can't be with the patient. And they were like divorced from the family completely, except for an hour, when family could come visit them and had to leave. And that was the case even when I started practicing. We gradually got those things changed. Not that we got them changed, but some hospitals were a little bit more lenient about visiting hours. When the ICUs came, because there were no ICUs when I first started, either neonatal ICUs or surgical ICUs, medical ICUs, cardiac ICUs, pulmonary ICUs. There was none of those. Can you imagine the division now? Intensive care unit. And they didn't want visitors around because the visitors might be challenging what was going on with the patient. They were too busy taking care of the patient. They didn't want people asking questions or being challenged. But all of that, thank God, gradually changed. And it came about by patient-centered care, which we're going to go into, and shared decision-making, so that communication would be improved. The big thing is patient and family education, which we still have big issues with. So hospitals today are certainly more relaxed. They do allow people to stay with the family, stay with the patient. They will even let the patient have somebody with them overnight, which the first time I was exposed to that, I was totally shocked that we were going to do this. And especially on OB units. The babies, usually in my day when I first started, the babies were only in the nursery. There was no such thing as a baby with its mother. And the baby came out every 4 hours for feeding and back into the nursery. Now you have to remember, just take that, OB alone. You know, before women delivered in hospitals, they delivered at home. And yes, the maternal mortality was high. But they breastfed the babies. There was no formula. And if they couldn't breastfeed, then they found somebody who could do it for them. Well, the doctors and the role of pediatrics began to change. And they felt that they were specialists in the babies, and that babies in the first 24 hours of life had to adjust to being out of the mom and into the world. So they were not fed at all for 24 hours.
It's in the high classes, kings or all, I don't know, but they don't want the queens to give the breastfeeding, the slaves or somebody giving the breastfeeding to the children. Do you know something?
They didn't want, or that's what they did want? I don't know which one you're saying. They did not want the slaves to feed, or the servants?
No, they want the slaves to do it. They didn't want.
Right,
because the
high
class, because they were thinking that they're high class.
Yeah, exactly. This was beneath their dignity to breastfeed the baby, and it was something that you had to do in private anyway. It was just not something that they wanted to be any part of. That let somebody else feed the baby. And really, in all upper classes of society in the West, children were not taken care of by the mother if they were wealthy. They had nannies for everything. They might see the mother once a day for an hour among the wealthy. Oh yeah, my mother worked as a servant like that, and her boss, when she was taking care of the children, her boss only wanted to see them maybe an hour or an hour and a half in the afternoon. That's the way it was. That was what she grew up with too. So, it was very foreign to somebody coming from another world to see something like that my mother saw. So she really became a mom to all of them. But anyway, that's neither here nor there. So getting back now to the business of feeding children, then came, of course, the formula business. And of course, these formula companies are not going to give this up. Formulas are nothing but chemicals. And yet it's so hard to get women to breastfeed. It's really difficult. And that's part of patient education. No matter how much you educate, once they're home, finish. Once they're out of your sight, finish. No, not all, but a lot. So we made things trying to improve healthcare of children and survival and survival of women having childbirth, survival in surgical procedures, overall survivals. We changed everything from what was done at home to a separate environment, made it all very mechanical, dissociated, not integrated. And now we're trying to gradually move to keeping patients out of the hospital, to getting them out as soon as possible. And that's really related to infection. It's not related to anything else. The hospital-acquired infection is so bad that you want them out.
But it's not a rule, so it's not like people that go and check if the air is sterilized the place and all this stuff.
They're not, I'm sorry, I didn't quite get that.
Yeah, I understood. I don't know. when you are in the medical, well, in the hospital, when the patient leaves, they need to sterilize the room, everything.
You have to clean up the room completely, yes.
So this is not enough to keep away the infections.
No. It helps. It certainly helps a lot. But you know, you may clean up the room, you know, wash down the walls, the floors, the bathroom, but they don't wash down the hallway walls all day, every day. You know, they don't sterilize the people coming in and out, visiting or hospital staff or anybody else that comes in and out. They're not sterilized or controlled. Even today, there's less and less of this use of clothes in the hospital, not going out of the hospital. There was a period of time that what you wore in the hospital, okay, stayed in the hospital. Okay, you could bring it in from home, but you did not wear it from home. I mean, I can remember going after nurses and house staff that I saw on the train in scrubs, and now they're on my labor floor. I said, they'll change. But that's no longer the case. So, I mean, I don't know that that's the right thing to do. I really don't think so, because you're bringing in all kinds of things from the environment. But
I think you refer probably more specific procedure probably than general, like talking.
oh, between procedures, yes.
Like more specific probably surgeries
No,
and all the
sometimes-
materials. You're talking more about.
I'm talking about hospital-acquired infection.
Yeah, but probably she's talking more about
No,
the procedures and more specific with surgery.
That's
all the material has to be.
Oh yeah, all that. Every OR, when somebody goes into the OR, from the time they enter that OR, which has already been cleaned, everything in it cleaned, the anesthesia machine sometimes wiped down, not always, but certainly the airway tubing and everything else has all been cleansed. The floors and the walls have been cleansed most of the time, but not all of the time. Okay, the floor, yes, but the walls, no. That's only done on a regular basis, but not between every case in every facility. And the equipment that is used for the surgery is all sterilized. Yeah. Okay. And re-sterilized. If something drops, you know, it has to go back and be sterilized. You can't use it. Okay. So yeah, there's a great deal of sterility and care there about transmission of infection. Okay, now, before the Second World War, of course, the patients and the doctors kind of had this idea of trust in each other. And patients felt what the doctor said was the thing to do. And the doctor operated really on the idea of beneficence, doing what is best for the patient, and malfeasance, do no harm. However, patients wanted to get more involved and wanted to know more about what was happening. And so we enter now a different kind of relationship. Instead of this paternalistic, you know, I decide, I talk to you, I decide, and this is what you're going to do. Now we do more talking about it. Hospitals are more organized towards a patient-friendly environment. But the important thing, the most important thing to everything, okay, is trust and confidence in each other. And if you don't have that, if the doctor cannot trust the patient and the patient cannot trust the doctor, then we're in trouble. And that takes work. It's not something that a doctor walks in your office or you see them in the hospital or wherever the case may be, like walking to the dentist. It's not an automatic trust, okay? You're engaging in a business kind of thing. And so trust comes about from talking. And patients are notorious for coming in for one reason, and I want to come back to that in a second, but coming in for one reason, and after you spend, at one time you could do this, 45 minutes, an hour talking to a new patient, and finding out all the reasons the patient's there, they examine the patient, and now you're giving back feedback to the patient, and talking about what the possibilities are, blah, blah. And you go to the door, and the patient says, I have one more question. That's why she was there. So, or he, especially she, because that's all I took care of. That's why she was there. It was that, I have one more question. And it's like, okay, sit down and listen. Sometimes doctors didn't do that. A lot of times they didn't do that because they've already felt I've spent enough time. In today's world where you have 12, 15 minutes a patient, really things have to be done differently. And you don't have time for a lot of discussion. So you got to take care of one thing at a time. And that's a matter of patient education. Trying to get patients to understand that either they come in with a list of questions, okay, and then you take what do you say to the patient, which of these right now is most important? And that's the one we'll take care of now, and we'll take care of the others later. Because you don't have the time, okay? And you want to be able to discuss, you want to be able to share, you want to be able to explain, you want to hear what the patient feels, what the patient thinks, what the patient thinks they want. So it becomes, an education, negotiation, so on relationship. You want your office to be patient-friendly. That is a nice atmosphere. And one of the things I was reading as I was preparing for this was that in this attempt to have patient-centered care, which is true when you think about it, hospital facilities have built these beautiful atriums. They provide all kinds of food within the facility of the hospital. That's not patient-centered care. That's beautifying the environment, but that's not patient-centered care. Doctors' offices will do the same thing. They'll have plants and pictures, and that doesn't fulfill patient-centered care and patient-physician communication. It just makes it look pretty. Okay, maybe it's good so the environment looks nice rather than walking into a sterile situation, but that's not patient-centered care. Shared decision-making comes about by you talking to each other. And sometimes you cannot make a decision on one visit, okay, or in one encounter. Sometimes it takes multiple encounters, especially in a hospital environment where you've got all this participation of consultants from every walk of life, so to speak. And now all of this has to be put together, plus what the patient has been told by each one, okay? And some one person should be the coordinator of all this information. And sometimes it doesn't happen that way. That's where we often fail. And patients will tell you that. So it's very important in parts of this idea of patient-centered care that these 8 things be accounted for, okay? This came out originally from the Institute of Medicine back in the 90s, by the way, not until the 90s. And then it was formalized more carefully by the Pickering Institute, who then spent time interviewing, talking to patients, and getting their input as well. So it's important, as we all know, to respect patient values, okay? Because the patient has completely different values many times, not always, but many times than your values. And you have to understand what their values are before you can even talk about your own. So you have to know what their values are, what their preferences might be in terms of their own management, long-term, short-term, end of life, beginning of life, all of that. And what they really think they want, what they really feel they need. And all of this, it takes time. And so you wonder, how does it all happen? And sometimes I have to tell you, I wonder, Sue, how did it all happen? But it happens, not always, and not 100% of the time. We talked about multiple people being involved in care. This care has to be integrated and coordinated in a patient-centered environment. The information, communication, education, we are not good yet at education. We have to use technology much, much more to try to get the education out there. Sure, we have lots of patient pamphlets. You can read things on internet. You can't believe everything you read on internet. And believe me, patients come in with this whole thing printed out from internet, and you're like, oh, okay, we have to go through this piece by piece and explain why, yes, that's okay, why no, that's a no-no. You know, like somebody who's tried something on 2 animals and now the patient wants it on themselves, and you have to go through the whole explanation of why that cannot happen. And they don't understand that. I mean, they want to understand that. So you really have to spend time. Okay, and it really is communication. But we need to, as physicians, as healthcare providers in the field of medicine, we need to make education more available at the patient's level. You cannot tell somebody who went to the 5th or 6th grade or has a reading level even of that, give them the same educational information, same educational material as you give somebody who's had a high school or college diploma, maybe. Okay, maybe that's where they are too. Even when we would do hospital consent forms or patient consent forms in the office, I would sometimes read them and say, no. This doesn't sound to me like my patient's really going to understand what's written here. But the lawyers take so much part in all of this because of the medical legal situation of medicine. And as the physician, you're trying to work with the lawyer to explain to the lawyer, I don't care what you say. You might tell me this is 6th grade reading. I don't think it's 6th grade reading. I don't think half of my patients are really going to understand that. And many of my patients went beyond the 6th grade because it's legalistic.
Yeah.
Okay, it's so legalistic that it's very difficult to understand. And the other thing about it is they don't read it, no matter what you say. You put a consent form in front of them, now I want you to read this, and I'll come back and ask you if you have any questions. They've already signed it by the time you get back.
It's like about balance, when you vote, they explain you the amendments, and you read, you don't understand, because then they say yes.
It's very difficult.
And you don't know what you want.
It is I agree with you, it is very, very difficult. Yeah. And so you have to, if you don't spend time as a physician with the patient going through the consent form, then as far as I have been concerned, and many of my colleagues, that's not truly a good consent form. Mm-hmm. But when you start to explain to the patient, as you have to, the risks, and you go through the risks, and you give them the most common risks, and then you go through the uncommon ones, and of course you could die. And some of them will look at you, you mean I could die? How many people die? How often does why are you scaring me? Mm. And it is scary. It is very scary. Mm-hmm. But you have to then spend the time trying to work with them to understand, death is way out there. You could die getting out of this bed, okay? And I have nothing to do with that. But if you're dying under my hands, I have something to do with that, and I have to explain that to you. So just trying to get information to the patient in the patient's understanding. On top of that, we deal with a very pluralistic society. We deal with a multilingual society, and many patients don't speak English. And even if they do, and were born and raised in this country, it may depend upon where they come from as to what their English is like. Because you may not be able to understand them, and they listen to you, and they don't understand what you're saying because of your accent or the area of the country you came from. You say things differently, you pronounce things differently, you don't understand the terminology they're using, okay? So it's really important to try, and it's going to take time. It's not going to be something that's going to happen overnight. I mean, after all, we've only really been working hard at this for about 60 years, and if I want to say super hard, probably for the last 25 years, okay? So dealing with more with pluralism, the immigrants that we have too have changed, and their philosophies and the kind of world they come from and what they're used to. They're used to the doctor tells you what to do. Okay, and then when you start discussing with them, whatever you say, doctor. No, it's not whatever I say. And you got to spend the time. Well, I don't know. They don't know. They look at you. Why do I have to go under this? Why do I have to under? Where I come from, this is not what they do. You do what you think you have to do.
Because you are supposed to know that you are doing.
Yeah, you're supposed to know.
If I am coming to you, is because I am trusting in your expertise.
Exactly. Well, that's what we're talking about: trust, confidence, truth. Truth is important. Yes, Claudia.
I have the point that you just said. The Three Virtues organization doing a session about drugs. What you said is very true. Is the doctor gave the patient the medication, the drugs, but they don't ask why am I taking that prescription, that drugs? So therefore, the patient continue taking that medication that not even related to the problem. So right now, we are doing with the Three Virtues organization, education with the Spanish community, the Haitian community, and also in the after-school program to let the patient know you need to ask your doctor why you give me that medication. I think it's very important.
Exactly. You know, and that comes into when writing the prescription too. There are some, I'll give you an example as a patient. I would never have done this, but as a patient, I went to have some minor surgical procedure done, and the physician mentioned pain medication. And I said, no, I really don't need it. So he gave me the prescription anyway for 40 Percocets. For a minor 40 Percocets. And you want to know why you have opioid addiction? Okay, because we went through, you have to understand this. This comes from this physical comfort. Because there was a period of time when it was felt that doctors did not pay attention to patients' pain. We left them in pain. We did not treat them for their pain. We did not give them enough pain medication. And so the whole philosophy moved towards give them everything.
How was the philosophy before? Like, for example, they have pain, just the pain's gone for a while?
No, we would give them pain medication that we thought suited them, okay? And only for short periods of time. And if they didn't complain, they didn't get more. You'd ask. If you didn't, you were supposed to ask, but no, sometimes they didn't ask, okay? And so the solution to that was doctor didn't give enough pain medication often enough, so you give them everything they might need, and as much as you think they might need, which is more than what they need.
No, but you said that has changed, because now I know.
No, it's changing.
Yeah, anything they have pain, they have to be, the patient is there because they need for the pain. But a long time ago, like you said, before the change.
There wasn't all this pain medication to begin with.
So how was the work? What did those work? Let's say, okay, you have pain, just go home and you'll be okay. How was that?
Yeah, a lot of that was okay. So you have some pain. What kind of pain do you have? What is it like? Well, why don't you just, take well, how did we used to do that? The aspirin was the big thing. Aspirin for everything. And then ibuprofen came out, but after aspirin was the big thing. And it's probably still one of the best drugs in the whole wide world for pain relief, really. Tylenol came along. Narcotics were only used in the hospital environment. They were not used outside of the hospital or in the doctor's office given an injection. Then we got to the point where narcotics could be given. I mean, you had to have a DEA number and all of that, which you didn't have to have years ago. But then you had to have a DEA number to prescribe narcotics. And then it was over prescribing. Okay. And this is why we have, you have to understand too, when it comes to addict epidemics, we have them in various cycles. Okay. And in my career of medicine, when I first went to New York, it was, not heroin, cocaine. No, heroin, it was heroin. And then that went down. Then I came to Miami. It was cocaine, sifting, everything with cocaine. And then, that kind of, we sort of was able to get that under control. And now you've got all these mixed because of these new drugs. Those drugs were not available 15, 20 years ago. They are now the cause of these epidemics. And pain clinics everywhere because people want pain relief. People don't want to put up with any kind of pain at all. And for example, let me just tell you, back pain, we are human beings standing up since humanoids we came to be, all right? But most of us we all came from four-legged creatures. And we weren't made to stand up. And not only were we not made to stand up, we were not made to stand up for 70, 80, 90 years. We were not made to stand up doing some of the things of the job you have in today's world. And so chronic back pain is a big issue. There is really relatively little out there for chronic pain, chronic back pain, okay? Opioids don't work. The other types of pain relievers like gabapentin, they don't work. Rehab helps, but people don't want to go. They don't want to do physio. They don't want to exercise themselves. They don't want to get the back supports that they need. They want, just give me a pill and it'll go away. So anyway, it's such the opioid epidemic. But that now is changing with the laws that are being imposed on doctors, which in a sense I wish didn't have to be, because I think the doctor should have the right to write a prescription for 7 days instead of having the patient every 48 hours or every 72 hours having to go back to the pharmacy to get a prescription filled, okay? But maybe that's a good thing too, because if they're doing that, and you're the one that has to phone in the prescription, you're more aware that she's using more than she should be using, okay? Or he's using more than he should be using. But now there's laws they're trying to pass, I know, in several states, particularly in the state of Florida, where the physician can only write a prescription for 48 to 72 hours. And then the patient has to go get it again. Well, that's not really patient-centered, but now the family can pick these things up as long as they're identified as a friend or a person of the family. And if you go to the pharmacy to pick up the prescription, the pharmacist is going to assume, if you know the patient's address, that, and they ask you the same question, they're going to assume that it's okay to give you the prescription. Okay, now the other thing too about pain is finding the source of pain, not only because of its anatomical location, but also the patient's concept of pain, the family's concept, because believe me, families can really make it difficult, okay? They can really make it difficult. So you have to really work with all of that, and you have to spend time explaining to patients that this isn't going to kill them. This isn't going to totally incapacitate them. This is time limited. Most chronic back pain is like, say, 3-6 weeks. By 6 weeks, most of the time, not all, but most of the time, people are a lot better. And I have friends still who will, say, I want the doctor to do a CAT scan. Well, okay, you can have, maybe the doctor will do the CAT scan, but I'll tell you, it's a waste of money because it's not going to tell you anything that you don't already know. It's not going to change the diagnosis, and it's not going to change what he does. But you know what? A CAT scan costs a lot of money. And so,
a lot more radiation than X-rays, like, I don't know how many times more, like thousands.
Oh, yeah. And, that drives up the cost of care. And like last week when we had our talk with Dr. Martinez, and he's trying to point these things out, and really patients' demands without adequate education makes it difficult. And then if the doctor doesn't do what the patient wants, then, he may lose the patient. Never mind, he should have a conscience of his own. On the other hand, you don't want to offend the patient either. And you don't want the patient to feel like you're not caring.
But
yeah.
Obviously, the situation is converting that the patient is the doctor because he read
He read something here.
In the internet and come to you and tell you,
I want this.
You need to do this.
Mm-hmm.
And that is not correct. That's why, for example, people of Latin America comes to you knowing that you are the one that is knowing what you are doing.
Oh, sure.
So it's a balance, but it's stupid. I'm sorry, but it's stupid to let the patient take control of the situation.
Well, we're going to talk about that as I go on here. But you're right. You're 100% correct. There's all kinds of things that have to go on. There's just so much concern from the medical legal situation because we get sued so much, okay? And sometimes you get sued in a situation you never expected it to come from there. Like, huh? But, and so doctors are very tuned to that. They don't want to lose their patients. They don't want the patients to go out of the office and be dissatisfied. So everybody else sitting out there is dissatisfied. They want to please the patient, okay? But that has to be done in different ways. And like you say, it depends upon where the patient's coming from as to how you relate to the patient. So the other thing is involvement of family and friends. We're in the world today to encourage patients to bring somebody with you, okay? Especially if you're going in for an oncology situation or a serious illness, bring somebody with you who's going to sit and write down the discussion. Because if somebody is with you and somebody writes it down, okay, what the doctor said, what the patient heard, and what the third person is involved in, they're like, they weren't on the same place at all. But if it's written down, and the doctor ideally should be able to write down what he says too. But we also now face this other issue, okay? The doctor's trying to talk to the patient and they're in here and they're to the patient, and you're not talking to the patient, you're talking to the machine. And that divorces the patient's, the patient's like, he doesn't care. But you have no choice if you're going to properly document. You could do it handwritten. I think it was easier, but okay. Then the next thing is when you move patients, like change level of care, or the patient is transitioned to another physician because of the condition the patient has, that has to be done in a smooth, unified, cooperative way, which doesn't always happen. But, and the physician who is transitioning over ideally should go and at least visit the patient once after the transition. I mean, that would be the nicest thing to do, but it doesn't always happen. And then access to care is always a big issue. Always has been, always will be. You know, how to get care, where to get it, how far away it is from you, how do you get there, transportation, is it the kind of care you want, how far away is the nearest hospital? All of these are concerns. And when access to care, everybody wants access to the best care, not just to care, but to the best care. Okay, now one of these other things is respecting and recognition of religious beliefs. This was never an issue in the past. We didn't deal with that. I mean, I say most people didn't deal with that. But patients didn't always like to be asked what their religion was. And sometimes you just had to wait and figure out how you could get that information out of them. But we have to recognize that different patients have different religious beliefs, and so do we, okay? And so, well, when we go into shared decision-making, we'll talk a little bit more about that. But it is very important to recognize, and that research has shown this now in the last about 20 years, that patients who do have faith, some kind of a religious belief, okay, do better under the same circumstances as the one who does not, okay? Even to the point that the person who attends a church service on a regular basis even does better than the one who has a belief but doesn't attend church services. So the extent of your religious belief makes a difference. And it also allows the patient to accept devastating situations better. Okay, helps them accept it and helps them deal with it.
So, excuse me, you have to see the acceptance, medical condition. That's what it helps.
Accepting.
The religious person who has any kind of religion, right? That's the idea.
Say that again?
Yeah, because you talk about patient values and religious belief.
Right.
How it helps in this? What is the purpose of
accepting religious beliefs or understanding them?
for the patient?
Because you have to understand the patient, where the patient's coming from.
Right.
Okay, and accepting their beliefs, what they tell you they want, based upon what their religious belief is, you have to respect that. You may not agree with it, but you have to respect it. And it may become a subject of discussion in care, in managing the patient.
No, but what makes the difference when you say when they go to the service or go to mass or any kind of...
What makes a difference?
Yeah, the practice make them the difference. And
I think a lot of people would like the answer to that question. Why does it make a difference? It's not something that you could put your finger on in a research project, that kind of thing. But it really is because they just have a faith that everything is going to be fine, or everything is going to be okay, or they know where they're going at the end of their journey. Where people have this journey in life and they don't know where they're going and they don't have any belief in anything, okay? They're discontented people on a general basis, okay? Whereas when people who are like this, I hear me say women because that's what I'm used to, but people who have beliefs have a whole different idea of their journey in this life. And they're much more accepting of bad events.
Or
yeah.
Things.
Well,
they are more open to, okay.
They're more open and they just, yeah, Lydia.
I think that by going to services, you're allowing it to grow, you're nurturing it. It's not something that, okay, I have the belief, but I don't necessarily do anything about it.
Right.
But when you exercise it, it's just like anything else that you're exercising. It's an outward sign, and you're also receiving at the same time. So it's something that builds your spirituality, builds within you.
Okay, I got it. So,
Yes, Patrick.
Thank you.
So I guess to make the abstract more concrete, at Mercy Hospital right now, we're Mary Jo and Lydia. One of the biggest differences between Mercy Hospital and other facilities in the area is the pastoral care department, and how the pastoral care has transformed patient care has been in the way that patients are more receptive to physicians, more receptive to the patient care team. It actually helps with basically speaking their language and giving them more comfort and care. And this has translated into actual increased rates of patient satisfaction because of this.
Oh yeah, there's no question that increases patient satisfaction. And I was going to come to that. Yes, because now many hospitals have chaplaincy services. The Baptist system does, right. The HCA system, and not just at Mercy, but at Kendall Regional, and would they have another one? Yeah, the Plantation. What's the other house? Jackson has always had chaplaincy services. Not always easily available, but they're there. I mean, the chaplain would come every day, but you try to get him in the middle of the night, and he'd say, "Baptize the patient yourself," which is true. But it does make a difference, because the patients then have a chance to talk over with a chaplain of their choice, okay, some of their issues. And it's amazing what comes out that they've hidden, they've got smoldering inside of them, it's crushed them. And now they have a chance to let it go. It's like going to confession, you know, they have a chance to let it go. And when you let it go, you feel better. And therefore you do better. Okay, and you accept better. So it's really important. And then I've talked about the bioethics committees, which did not start appearing. Again, chaplaincy services were only in the past in Catholic hospitals. Okay, in New York, when I was in New York in the 60s, we had a chaplain service at the city. All the city hospitals had them, and the chaplain visited every single patient before they went to the OR. When I came to Jackson, that didn't happen. But when you would call and say, "Get the chaplain because the patient's going to the OR." Why? Everybody, why? Well, because the patient might want to talk to the chaplain. Why? Okay, because maybe the patient wants to go to confession, you know. But in New York, we always had it in the city city hospitals. And then bioethics committees began really pretty much starting moving into hospitals in the 90s. But if you see what I say, very utilitarian in opinion, very, very so. And so in a Catholic hospital facility, one has to try and realize, get the people on these committees and the patients to realize that, no, that we don't function that way. We don't look at what it costs to do this or what it costs to do that. We look at what is in the best interest of the patient in the care of that individual with that patient's values and your physician values. Yes, Lydia.
I just wanted to add that there is a sort of secular response to this research, because it has been proven that these outcomes are improved for patients who do have religious beliefs. So in order to address that component, I guess the sort of atheistic secular world has come up with this whole idea around mindfulness, right? So mindfulness comes from these Eastern meditations and sort of Buddhist philosophy, so it does actually come out of a religion. But the response is, you know, let's get people to sort of center themselves and meditate without any religious component, which, you know, it's just really the patient being inside themselves. So the individual and themselves with no God component, nothing there. So there really isn't anything to give them back. It's just being able to center in yourself. But this is really taking off all the world and say, let's try to replace that religious component with something. Let's address that something and see if we can find the same great patient outcomes without introducing religion. So I just wanted to make you aware of that.
I'm glad you mentioned it, because I would not have brought that up, but you're right. And you'll see that in the hospitals with music therapy, with yoga, with all of this. It's, I mean, yes, music therapy helps. I mean, I will not deny that. It does cut down on pain too.
Mario, excuse me, do you see these things often in the utilitarian opinion and the bioethics community most?
Oh yes, we're facing this now. I mean, I at Jackson had to deal with that, and you know, I was resistant ever. In OB, it's, as those of you who do OB or know about OB, it's very, very difficult because the baby is extremely important. So as a mother, they're an important pair. And when I would have to, you know, we pushed that you have to get a bioethics committee meeting to discuss this patient. I knew that I was not, I knew what they were going to tell me to do. I was fully aware. I was like, I'm not going to do that. So I have to go listen to the bioethics committee. It was totally utilitarian, okay? For example, a woman has terminal heart disease. Let's say she's got a cyanotic heart disease and she's 18 weeks pregnant. Cyanotic means that she's blue, which means that the baby may or may not have some degree of decreased oxygenation, may or may not. But when there comes a point that she's going to deliver this baby, her whole cardiac status, her whole heart status is going to undergo dramatic change during labor and delivery. Labor and delivery is really work. It's real work. And the women, pregnant women, their whole physiology has changed during pregnancy. They have a much heavier cardiac load. They handle everything very differently. And so when she's going to go through labor and delivery, which is still the better option than a cesarean section for her, then the way her heart's going to work is going to change. And the mortality at one time for these women was 100%. Okay, 100% of these women were going to die. The woman decides she wants to carry the baby. And the hospital is saying, no, she has to abort the baby. So they call an ethics committee meeting. The ethics committee says the patient has to abort the pregnancy. Well, she's not going to abort it. Well, then she needs to go somewhere else. No, absolutely not. And so I would say no, and I'm not even going to tell her you said that. I'm going to tell her what you said, because I've already had this conversation. I already know what she wants, okay? I've spent the time. She knows that she might die at the end of this, or probably would. But that's the difference, because you have a bioethics committee, depending upon the facility that you're in and depending upon the physician and patient, is really how you follow what the bioethics committee says. And we're going through something right now at Mercy, and the previous bioethics committee has definitely a utilitarian idea, and we went to visit the patient and sorry, no, this is not the case. Absolutely not. So, you have to, they're important to have them, but we have, as again pointed out last week, and you'll see over and over again, we're living in a utilitarian world, relativism, liberalism, ethics is all of that, but it's not the ethics that this course is about. It's not the ethics that we should be using. We should be on a different level. And we have to accept it. We're not going to be accepted because of that, but we have to fight for that. And we have to practice that way ourselves. And we have to really believe in it ourselves. If we don't believe in it, then we're wasting our time, because you're going to go right there. Okay? And that's what the government wants. When he talked last week about socialized medicine, I'm not opposed to socialized medicine, because I believe every patient has the right to medical care. I really have never been the physician that was in a private office having to bill patients and all of that. But from what I've seen and what I've heard, I would never want to have been in that situation. Okay? So I knew nothing about billing, except every time they were going to raise the price for something, I was like, why? Okay, and nothing about billing. I know nothing about the business of medicine. And I really don't want to know. I'd rather be a salary doc who takes care of patients. Just pay me the salary, I know what I'm going to get, and that's it. But that's not the way doctors work. They went to medical school, they have these bills to pay, we all did. We had bills to pay, I didn't have a family, but if you have a family, a wife, children, they want to live at a certain level. That's not going to happen today. It's just not going to happen today. Unless you have, in addition to socialized medicine, insurance-based medicine, where a person can buy insurance to get added care. And that probably will happen. If you want to pay the money, insurance companies will do it. Okay, I think yes, this is about patient and physician's values. It is important, and we're going to discuss this in shared decision-making. It is important in some parts of this shared decision-making, depending upon which part you're going to function in, that you understand, all of it's about understanding patient values. But some of it has nothing to do with physician values. The physician does not express values at all. He doesn't have anything to say for or against the patient's values and the patient's preferences. And it brings up this situation. So if there is a difference and the physician cannot go with the patient, what the patient wants because of the physician's values or preferences, or because the patient doesn't want to do what the physician thinks is best for the patient because they have a different set of values or preferences, then each one has the right to walk away from the other one. It doesn't always work that way because there are times when the patient won't leave, okay, or the physician will bend. And you have to, this is part of shared decision making is going to involve that. But as each one has the right to decline or to say no to what the other one is offering. And then, you know, for example, if it's something that the physician refuses, the physician should provide alternate information about levels of care or alternate providers. Now, what do you do in our religious perspective about sterilization and abortion? I think it has to be very clear up front when you're accepting a patient, female patient for sterilization, since I don't know, yes, accepting a female patient for sterilization, if that patient says that she wants her tubes tied, then you got to make it very clear in the beginning, if you don't do it, you know, I'm sorry, I don't do that. Now, I'd be glad to have one of my colleagues take care of you. The patient says, no, I want you to do my cesarean section. So, well, I don't do the tubal ligation. And she said, okay, but what do we do about that? So the alternative is I get one of my colleagues who does do them, ask him if he'd be willing to do it. That would be my alternative, okay? Or the patient gets another physician. What about an abortion? That is the toughest one going, believe me. It really is tough because once you get to the point that no matter what you say, the patient is still determined to have an abortion, okay? You cannot refer that patient. You're not supposed to refer that patient in our religious beliefs or in a Catholic hospital.
But decline the service, yes. Decline the service.
You have to decline the service. And I have had patients say, well, what do you think about what should I do? Where should I go? And my answer has always been, almost always been, the telephone book, first page, begins with A. And I think you'll find facilities plentiful available. Or, since I was in a university environment, I would say, or ask my secretary. Because they always had lists out there. Now, what about a situation, and I've had this happen, Father and I talked about this yesterday, because I was trying to figure out how to deal with this here. I was chief of service at Jackson, and as a result of that, I had to make sure that the patients got what they wanted, regardless of my religious beliefs. So if a patient was determined to have an abortion, in, like, for example, a particular situation I know about, a second trimester abortion, and I know that there are people that no way should that person, and the hospital had to refer her, administration, no way should that patient go to that facility. But I knew of facilities that really were far better, far safer. What do I do? And what I did was, she's going to do it anyway. I don't really, in conscience, feel right about that she gets a referral to a facility that I know is dangerous. So I would say, why don't you tell her instead to go here? That this is, the doctors who do this here are better at what they do and safer. And you know, we discussed that quite a bit, and really you're referring a patient. But on the other hand, my feeling is I have to care about and for that patient too. And she's made her decision. She's going to do it. Nothing I say is going to change it. So at least let me make sure she gets the best of, you know. And I had a lot of, that was a big problem that 48 hours was tough. And the other thing is we cannot proselytize to patients. Okay, it's not appropriate. Okay, so you have the Catholic directives. You know exactly what the fiduciary responsibilities are as on your patient-physician relationship. Okay, and it's important to recognize that ideally neither should act independently of the other.
With that case you mentioned, there was no way to actually first initially refer her back to her primary care physician, and then the primary care can make the referral?
I probably could have done that. No, that one, no,
No?
because she was a Jackson patient. That one was a Jackson patient.
Or
So we were the primary care
was she a
facility.
Jackson Prime patient? Is that what she was?
Oh, in those days, we didn't have all those things.
They had some kind of brown card, right?
I don't
It's
know
like a
any
travel
about
card
cards.
between Jackson facilities.
I don't know anything about the cards. All I know is that when she's under our care,
You have to directly refer.
we have to do what you think is right.
Oh,
You know what I think is right.
You know, when I was working in the
And she was a Jackson patient from the beginning.
when I was working in the health department in the family clinic in Winnipeg,
Hablaba
they told us to if some woman knows she's pregnant and then she wants to have abortion, we cannot refer nobody to nothing, like you said, yellow page, and I cannot tell you anything.
Mm-hmm.
That is, it may come from some policy or protocol from the health department. They say no.
Well, they
you
didn't
say
want, the health
anything.
department didn't want to get into
Yeah.
get the name of referring patients for
Maybe,
abortion or
yeah,
being
maybe
abortion minded.
Talk about
Yeah.
when this started like 8 years and 10 years ago. They said no, say to nobody nothing about where they can go. You just I give you your service and that's it. So don't ask me about it. Oh, okay. So, but the supervisor who was there, she was a pro-choice, and probably she was not involved with the paper, so but. And then she would say, "Oh yeah, I think I went from that. When I was at a hospital before, it was yeah, they made abortion there, and but she was like a pro-choice, so she was doing her. Yeah.
It's amazing that the health department did that. I didn't know that.
But after she knew the happened since, she had to protect her, We call attention, she started to say, no.
Pilar.
5 minutes.
Okay.
5 more minutes.
All right. I think this is another thing. We don't even realize when we're taking care of patients that sometimes you do manipulate them.
Yeah.
Or they manipulate you. So you have to be kind of careful about that you're not twisting the patient into something. Yes, manipulation doesn't mean you're not educating them. It doesn't mean you stop communicating, but you got to be careful how you say what you say, okay? And again, intimidation, the patient do something because they're afraid of you. No, okay? They will be afraid of you, but sometimes you can get that out of them. And I try to find that out.
What about they think you are the king?
Well, you have to be careful. You don't want to be doing that. And the same thing with being condescending or acting condescending. They pick it up right away.
That's a video about the patient since doctors are king. And I was asking the person to send it because I was listening to her radio watching. This is from the United States. And they say whole malpractice because patients think doctors are king. And then it was like a half-hour video. It was interesting.
Well, I don't think they think that. I don't think so anymore. Okay, so what are some of the barriers to communication between patients and physicians? Okay, and I think that one of the things that is the way the physician is in an office environment or in a clinic environment says one thing. That you walk in, what's your first impression? Okay, and first impressions take a long time to go away. So if the first impression of a patient when they walk in the room is that the physician is standing with his back to the door, okay, and greets the patient saying hello without turning around, okay. The patient, when talking to the physician, gets the sense that that they're wasting the physician's time, okay. Maybe he's not listening. Maybe he doesn't hear what I'm saying because he's writing or he's typing, or he's constantly answering the phone. So, they have all kinds of ways of interpreting that they're wasting your time. The patients can be very embarrassed to discuss certain issues. And that's why you might, like I said, as you're walking out of the door after the hour-and-a-half visit, and the patient says, "But I have one more question." Okay. Sometimes you have to bring up issues because if you don't bring them up, they may not come up. One of them is violence. You know, you really have to discuss the whole business of domestic violence. You have to ask patients, have you ever been afraid of anybody? Has anybody ever hurt you? Have you ever been molested? If you don't ask the question, you're probably not going to find out for months. And this may be the basis of the whole patient's problem. And it's really total patient caring. Okay? Medical language. We shouldn't talk to the patients in medical language. It's hard not to. It's really hard not to talk in the terms you're used to talking. Even simple things like, have you had a bowel movement? Okay, so you go doo-doo, caca, what's the other one? Shit. I never heard these words at home. And so when I was exposed, it was like, oh my God, this is a whole new language. I never knew what a period was because my mother never used that terminology. Okay. She always used menstruation. And so the first time I heard the word period, I was like, what's that? So, you know, it's a language. Simple. It's so simple because we grow up with one language. Okay, that's the language we bring with us. And then we go into the world out there, and the world has other languages, even in English, I'm sure in Spanish. I mean, I know that there's some words in Spanish that you say to a Nicaraguan and you say to a Costa Rican or you say to a Managua, they have a different meaning altogether. Okay, Cuban, oh my God, you know, a different meaning altogether. So the words we use in medical language are almost sometimes as difficult. And it's very difficult. And if the patient does say, I don't understand, or there's a way you can find this out at the very end of the conversation by saying, okay, I want you to tell me what I told you. What did I tell you? What do you understand about what I told you? Okay. And what questions do you have now that maybe I haven't answered? Now, I say all of this to you, and I will also say to you that how do you do all of this in 10 to 12 minutes? I mean, I used to get a terrible time because my office hours would start at 8 o'clock in the morning, and I might not finish till midnight. And the administration will, why are you keeping these girls working? They don't get this break, they don't get that. So I don't do that. You schedule the patients, not me. You schedule the secretaries, not me. If I had my druthers, okay, I would have 2 shifts, but I don't have my druthers. You don't give me that choice. If I had my druthers, I wouldn't be scheduling 4 at 8, 4 at 8:15, 4 at 8:30, and 4 at 8:45. It's possible. It's now new time. And I still haven't seen my 9 o'clock patient. You know, I mean, you can't do it that way. And in today's world where we are forced really to keep up time because of patient satisfaction, then that's what we have to do. Okay? Okay, I'm going to 2 more words and then we'll stop. The doctor doesn't look like you and you don't look like the doctor. So you come from 2 worlds. And that's important. I mean, sometimes it's ideal if you can get patients and doctors that are the same, that they relate to each other by the way they look. And patients like that better. There's no question that they like it better. Okay, an Oriental likes an Oriental physician. Okay, a Black patient is much prefers a Black physician because they feel their understanding is different. Okay, and I can understand that. I mean, I think that's something we have to accept. And then the other thing is our own body language. Okay, patients have body language, we have body language, and how we use that body language. Okay, we take a break. And you have to do what you have to do. So please, any questions, please ask. Because now that we're getting into shared decision making, and that's okay, everybody, we're welcome back. You all hear us? Glardia?
Got it.
Okay, Glardia, are you there? No, she's turned off.
Is Ed there?
Ed's here, yeah. Ed, you do hear me, right?
Yes, ma'am.
Okay. Okay, great.
I'm here.
Oh, okay, fine. I was just waiting for you.
Thank you.
You're welcome. Now, let me see here.
Nice bedside manner.
Oh, did I switch the slide? Okay, how to overcome barriers. Well, I think the most important thing is, you all know yourselves how you would like to be approached by a physician. You all know yourselves what makes you comfortable in the doctor's office. So sitting looking at this slide really doesn't change any of that, does it? Okay? You need to make eye contact, the atmosphere should be comfortable. Don't interrupt, that's the big thing. Let the patient talk. And it's okay if there's a period of silence where the patient is not saying anything, but you know they're ruminating about something. Wait, hopefully, let them wait. Make sure that they're aware that you're paying attention to them, okay? When they express feelings, accept that and tell them it's okay. I mean, if they're angry about this one or they're angry about that one or they think somebody treated them wrong, it's okay to think that, it's okay. During the physical examination, it's amazing how a doctor can sit and examine a patient, stand and examine a patient and not say a word and say, okay, I'll see you in the office afterwards. Instead of, while you're examining them, explaining what's going on, what you're doing, what it means, what you found, always ask about concerns. And then, like I said before, ask the patient what they understood of what you said. This is what we should be doing. Okay, now we're going to get into a little bit more about shared decision-making. And we need to look at, as physicians, we should be really trying to put ourselves in the patient's chair, okay? And I've always said that every physician should be a patient. Because if you've not been a patient, it is very difficult to put yourself in that situation. When you've been a patient and you see all these things that go on, it's a whole different ballgame. And I'm so glad I had that opportunity to be a patient several times in my lifetime, the first time being as a medical student and realizing, like, why are you doing this? Why is this happening? Not understanding and not being communicated with. And, it was really a good experience. So you have to do that. You've got to try and, as a doctor, this is what we have to do. So in giving or talking about patient-centered care, it's really important that the patient be informed, okay? So you have to teach, you have to explain, you have to educate, and you have to leave the door open for questions, okay? An informed patient can make better decisions, but if they're not informed, they cannot make good decisions. They can just demand. I heard such and such and so and so, therefore I want that. Now you gotta try and educate them why, and this may not be for you. This may not be the procedure that you should have. And that becomes important, especially when you're doing things like prenatal testing. Because, right now, every woman is offered screening. I don't even know that they're offered so much as you're going to have prenatal screening, and now it's usually getting more and more towards it's only a blood test, and it's in the first trimester, and it's combined with an ultrasound maybe at 11 weeks and then again at 18 weeks. They need to understand why they're going through the testing, what the testing could tell them, what it will not tell them, okay? What the risks and benefits of that testing are all about, okay? And find out from them, why do they want to go through the testing? What is your reason for being tested? Some of them will tell you, look, you say I have to do it. No. That's not the reason to be tested. If you're doing it only because I say you have to do it, I never said that. You have to explain to me why you would like this test to be done. Now, there's another concern in here that we have to bring up from the Catholic perspective, and that is that if it's the patient's intent that she will abort a pregnancy, if that pregnancy is abnormal from prenatal diagnosis, if that is her intent and there's no way around it, then you really shouldn't be taking care of her. She should be referred. Because she's already declared what she's going to do. And that way you're legitimizing, if you keep taking care of her, you're legitimizing her decision. That this is what she's getting tested to kill the baby, if it's not good. Another way of that was a way that I often would use too, was that, yeah, I know that that's what she's probably thinking she's going to do, or is she's thinking she's going to do. Maybe I have the opportunity to change her mind. And so I would discuss with her, well, if the baby has Down syndrome, what do you think? Oh, I'm gonna have an abortion. Why? Well, I can't have a baby with Down syndrome. They're this, they're that, they're the other thing. And then I would tell them about my sister-in-law's niece. And then I would tell them about one patient that I had who had Downs, her child had Downs. And then I would tell them about the boy across the street who has Downs. And then I'd tell them about independent living. You know, it gives you a chance to educate them. But it's not just her. That's another issue. A baby is not just her decision. Family can pressure you off the wall. And the poor woman, maybe she doesn't want an abortion, but she's pressure, family, mother, father, sisters, brothers, husband, baby's father, whatever. And I don't want to do it. And, you know, to get her not to do it is very difficult. And I remember again, walking down the street by Cedars one day, and there's this lady whose baby had a fairly severe neural tube defect, and she kept the baby. And her husband was just, didn't want any part of this. So the baby's now about 18 months old, and I ran into the baby and the father. And the baby's in the stroller. And I stopped to talk to him, and he says, it's because of you I have to do this. And I go, oh, God, what does this poor woman put up with at home? Because of you, I have to do this. But he was still involved, obviously, in some way. Otherwise, he wouldn't have been the only one wheeling the baby in the stroller. But it's like the knife that goes through your heart. But these things are not easy, and in our own world where everything, this is the utilitarian attitude. The utilitarian attitude is that if the child is not perfectly normal, I don't want it. And when patients would come in and say, I want the perfect baby. So what's a perfect baby? A perfectly normal baby, perfect. I said, well, okay, we can have a normal pregnancy. We can have a normal labor and delivery. We can have a normal baby. The baby can leave here to the hospital, and 6 weeks later, the baby gets infected and it's got encephalitis and meningitis, and it's not normal at all. Well, that can be prevented? No, not necessarily. Cerebral palsy. I can't tell you that I can deliver a baby that doesn't have cerebral palsy, because that's a diagnosis you don't make until the baby's 18 months old. And sometimes they have to be 2 years old. So I'm not sure what you mean by the perfect baby. I think if you want the perfect baby, don't get pregnant. Because there's no such thing as perfect. It sounded so harsh. The first time I said it, I felt like, oh, this is a terrible thing to say. But I started using it because it made sense. And the patients began to recognize that you can't be perfect. They're not perfect. How do they think the baby can be perfect?
It's terrible. They are telling you that.
Oh, yeah.
That is terrible.
Well, it's that, again, it's all about utilitarianism. It's about, this is the way it should be. Okay, so now let's get into the models of patient care. The paternalistic is the one that, we just mentioned, that the doctor knows best. The patient doesn't really participate that much in the decision-making at all. He tells the doctor what his problems are. The doctor makes the diagnosis. The doctor tells him the diagnosis. The doctor then, with his consent, orders the tests to prove that diagnosis. The doctor then says, okay, this is the treatment we're going to have. The patient says yes. Okay, totally doctor-driven. Totally. Now, you can take that another way, okay, in that it can start out that way, and then you can start talking to the patient. Now, this is what you have. What do you think about this? Okay, and get some feeling from the patient. And as the more you get from the patient, okay, even though it may still be paternalistic, you are getting from the patient some of the values the patient has and some of the preferences the patient has. But you may or may not share your own values or your own preferences. In the end, what you end up doing is understanding the patient's values and the patient's preferences. You then make the decision based on that. So it's a paternalistic decision in that you're telling the patient, giving the patient what they're going to do, but you may have changed what you would have done had you not had input from the patient. Okay, and that's what you try to do. And there are patients that this is exactly what you have to do. Okay, like for example, the patient who comes is used to the doctor telling them everything from the society that they come from. That's fine, but now you try to get them to participate in some way, so you understand why something about them. Maybe the decision you make isn't going to be the decision that should have been made for them if you don't know where they're coming from, what they're thinking, what they're doing, what they understand. Okay? But the decision is still the doctor's decision. Okay? Once it becomes participation with the patient, it's a different story. So now, this is just sharing the information between patients, family, and friends. And we're now discussing, we're having much more of a discussion about the patient, what the patient wants, what the patient's family wants, in terms of, first when they come in, you have the first discussion, do you want family involved? You want friends involved? Let's bring them in. Let's talk about what we found, what we think, what you want, what your family wants, what your friends think you should have this shared discussion, okay? And, you know, all of their values, all of the preferences of everybody involved. So everybody has a say. And then the physician may also share some of his preferences or values. And together then, you all have a better understanding of each other and you have a better understanding of the facts, and then you make the decision about care based upon all of this interrelationship. There's no negotiation. It's not that you're pushing the patient to do one thing or the other. You and the patient together are making the decision based upon what you've talked about. Okay? Got it? Now, getting the patient involved is what we talked about. Getting them involved, getting them to participate in the decision. That's, again, you have to do some education. You have to support them in their preferences and ideals. You have to give them plenty of opportunity to ask questions. Open the door. You really become the patient's coach, counselor, friend, guide, but not decision maker. Okay? And together then you make decisions. And you use, the big thing here is to try to get as much information to the patient about their disease or entity or pathology or normality that you can, using patient education tools and technology if it's available. Okay, now here is a little bit different in that the patient, the physician does more interpretation of what's going on with the patient, okay? He tries to assess what the patient really wants, tries to interpret those values. It's not just understand, now interpret them. That means that you take what the patient's telling you and you may change it in such a way in your communication with the patient to interpret what you think the patient means. Because you may understand that they're telling you this one thing, but that's not really what they're at. So you're trying to help them interpret what they think they want, okay? And you, again, you give them as much information as you can, but the big thing here is that you're assuming that the patient really does know their values and the patient really does know their preferences. Yet at the very top, you're not sure. In the beginning, you're not sure. In the end, you have to assume that the patient really does know what they want and does know how they want it done. And you don't at all have input into this, in the sense you only sit, you listen, you follow. Okay? But you don't give what your preferences are or what you think the patient should do. Okay? So it's trying to understand as much as possible that you can about what the patient wants, what the patient's goals are, what the patient thinks the future is going to be, how the patient wants things done. So you facilitate it now, okay? You facilitate what the patient wants. Essentially, the patient's almost making all of the decisions, but you facilitate those decisions and carrying them out. And then there's the one where you discuss back and forth. You know, patient thinks this, well, this is what I think. I see what you're saying, but in point of fact, you have to realize that this might be a better option. My feeling is that this, in your circumstances, under this set of circumstances, under this situation, this might be the best way for you, or this might be the best test for you to have. or this might be the best treatment for you to have. Okay. For example, a patient comes into your office and says, I'll give you a situation that I know very well. A friend of mine who had prostate cancer. And there's all kinds of ways today to treat prostate cancer. And especially in an older individual, it's not as aggressive a disease as it is in somebody under the age of 50. So this guy comes into the office and he wants the prostate out. And the doctor is trying to explain to him that, there are other options. Okay, there's the option of radiation. You can have seed implants. We can do nothing. We can just watch it, do nothing. Okay, this is not an aggressive disease. In this particular case, in your age, we could do nothing. In his case, he did need something done because he was having a lot of hematuria. So something was going to have to be done. But no matter what the doctor said, no matter all the talk about incontinence, the risk of incontinence, didn't matter. Didn't matter. I want it out. Okay, so now the patient has totally decided and dictates the care. What you would like to be able to do is, in that situation, with the deliberation and the discussion with the patient, get them to come around to make a more conservative plan. So that's all about deliberative or really lots of discussion, negotiation almost. So there's the one where they tell you what they want, no matter. There's the one where you deliberate, you discuss, you talk. You really have to get to know them. And sometimes this is not easy. And they have to get to know you, and that's not easy too. Okay? And then this is the one you're talking about. The patient comes in, I've read all this on the internet. This is what I want. I don't want to hear what you have to say. This is how I want it done. This is when I want it done. Aha, the patient who wants a primary cesarean section. Primary, elective, non-indicated, except I want cesarean section. No discussion. By the way, this is a major procedure. You could die. But people don't die from cesarean sections today. Well, not everybody. There's always one out there. Okay. But I want it because I want the baby at this time. I want all these people there. I want it at this hour of the morning. I want to be able to do it when I have no work to do and I can get this time off. I want my husband that he can get his paternity leave at this time too. So it totally dictates the care. And you all do nothing more than do it. So that's total patient autonomy. Now this is discussion about back and forth, and this kind of thing you can really read about more than because we've discussed it in such a way, but the whole idea here is that the patient comes in with their set of ideas, but you start negotiating, deliberating, working, trying to get them to understand another way, and you to understand their way, and somewhere between you will come into a situation, okay? When I was reading all of this, I'm trying to put this together for this talk, I'm like, oh my God, I guess I did all of these things, but I never thought of them this way. I never thought about which way was which and which way. You do it what you have to do with each patient. But this group, at the end of all of this, I gave you 3 references. Because I think it's kind of important in a situation like this, that maybe you go and read the original 3 papers. And there are others, but these 3, actually 2 papers, Emanuel, and Sandstrom, I think was the other one. It's in the last slide, are very detailed about shared decision making. And while Emanuel and Emanuel published their work in the late 90s.
What is Emanuel?
That's their name, the authors. The author's name is Emanuel.
Exactly. I was about to ask you, in the previous slide, you had Emanuel.
Yeah, that's because I'm trying to.
Excuse me, what did you say? Emmanuel is what?
The name of the author of the paper who discusses these methods. Okay, and that's why I said in the last slide, I put that there because there are 2 different groups that are looking at this and describing them, and he's got 4. The 2 manuals have 4 patients, 4 shared delivery, 4 patient shared decision-making methods. The other guy has 8. So, it's somewhere in between all of this is what we do, okay? but just so that you are familiar with them. And I think that it would be a good idea. They're on internet, or I can email them to you because I downloaded them just so I would have them too. Because I didn't really think about this way until Father said I had to do this. So it's a for me, it was mind opening. So I think for you guys, it probably would be good if you have the time, just go to read the original articles, okay? But whatever you send to Father, just summarize from this stuff, okay? Don't go. Okay? In this particular one, with the deliberative one, even though it's all autonomy, you're trying to persuade the patient. For example, you're trying to persuade the patient about lifestyle. You know, patient's fat, obese, smokes, drinks, and has unsafe sex. You really want to try and direct their lifestyle, okay? But they have the decision. They make the decision. You don't make the decision. So it's total patient autonomy, but at the same time, you are trying to teach the patient, and they call that deliberative. Okay, so now, obviously, there are certain situations in which you can't have these discussions. So a person who comes into the emergency room who's unconscious, you're going to be totally paternalistic. Unless there's family there with them. Then, you know, you make initial paternal decisions, you make decisions based exactly on what you see. And there's no participation. And then you get the family, and you go out and you talk to the family, and there are things you might change after talking to the family, okay? So there are circumstances under which you do make the decision without the patient, okay? There are times after many discussions with the patient, you fully understand the patient, okay? You fully understand what the patient wants. You don't have to keep going back to them to get their consent for to discuss with them every little detail, because you already know most of what they want, so you make decisions based upon that. So it's a mixed paternalism, patient deliberative kind of thing. And that's really the way it's done. We also can frame our discussions. That is, we can, and this is where we have to be very careful, because when we frame, we're giving our biases, okay? And when you put in your biases, you're really persuading the patient in a direction that may not be where the patient wants to go. And the patient doesn't know how to object. So you have to be careful about how you discuss something. You discuss facts until you get preferences, till you get values. Then once you know values, once you know preferences, then you have a better idea how to frame what you want to talk about, or how to present the information to the patient. Okay, now HIPAA. I don't know what Mr. Clinton had any idea that HIPAA was going to become what it became. I mean, it was a simple law until the lawyers got to it. And like everything the lawyers get to, what was a few pages became volumes. And then Obama added on to it high-tech and ERA. And it's just like volumes of rules and regulations that nobody really understands. Even the lawyers have trouble understanding them. And they write these legal documents, and they're so that nobody, I mean, you can't interpret them. And I've seen lawyers say, I have no idea what this means. And they're the county hot lawyers that have to help you make a decision about something. I have no idea what this means. I don't understand this at all. In the end, when it comes to the patient, okay, it actually is a lot of common sense, okay? We go back to, some of this came about, I think, as a result of the period of time when AIDS was endemic, or epidemic almost, and partners were living together but not married, okay? There was no marriage, put that way, like there is today. And you couldn't give information. You were not allowed, this was when HIPAA first came, we were not allowed to give out information. We could only speak to the patient and the patient's blood family. But never mind that you were the sole provider of that patient, okay, no. And to some degree, that still exists, but not as bad as it was then. So now if the patient has family around and you say to the patient, if the patient brings the family in, always clear, is it okay if I say everything? Yes. Okay, then you can tell them whatever you want, except the nature of the disease. The patient has to tell them first. You cannot tell them the nature of the disease. Because if you do that, then you're giving confidential information. Once that has been discussed in front of the patient, if that's that discussion and the patient wants everything discussed, once it's been done in front of the patient, then you can tell them anything there is to tell them thereafter. Okay, and it really is nothing more than plain, ordinary common sense. The problem becomes when medical records have to go out of hospitals, or go between physicians, or go to doctors' offices. You know, you need consent forms for a lot of that. You know, the patient has to sign a release of records. Okay, or people have their information on their computers, and they take the computers out of the hospital, and the computer gets stolen. Then you're liable. Okay, in hospitals, hospital staff have access to the computers, the same computers that everybody else uses, but many of them don't have access to medical records. So access to medical records is restricted, and you have to have a passcode to get into those medical records. So there are limitations. And there are laws that if, let's say, a hospital staff member wants to get information for somebody, about a friend of somebody, and that friend is in the hospital, and she goes in, she doesn't have to be, she goes into the medical record, somehow gets the information, goes to the chart, looks at it, you know, nobody's watching her, she loses her job for that. And she can be prosecuted for that, she or he. So people are very much aware that this is not the right thing to do. And I've seen vindictive people go get information and then tell the boyfriend's girlfriend, that kind of thing. I've seen that happen. And yeah, they lose their job, and they will not be ever hired in a hospital facility again because you can't do that. So HIPAA is really involving. Once you involve family, once you involve friends, it's so much easier then to give the information. Okay. As a physician, though, it's always a good idea to say to the patient, how much do you want me to say, and how much do you not want me to say? The one thing you don't talk about is sexually related issues. That's definitely a no-no. So like you have a teenager, you don't tell the teenager's mom what the teenager's been doing with her sex life, or that she's had an abortion, or that she wants contraception. That's private information. Okay? And parents sometimes get very huffy about it. But you know, if you're going to have the teenager as a patient, the teen has to be confident that you're going to not release the information. Otherwise, it's an issue. So you're not allowed to tell them, the parent, about the teen. Now, you have to watch the state laws, because some states don't necessarily. Florida does, but other states don't necessarily allow you to do that.
Mario, I'm talking this with some students about HIPAA, and the one student was telling me the history about the girlfriend that was sleeping in the room with the patient. So like normal, like about many days, and then that patient has some kind of infection disease, who was a transmission sexual disease. So when the nurse want to give the medication to the patient wasn't in the room. So when he came back, the girlfriend went to asking the nurse for the medication, and the nurse said, "Oh, okay, give the medication because for his disease." And she didn't know he has a disease. And then after she realized that he was sick, because he told her he went there for some other reason.
Mm-hmm. Well, that's why it's very important.
And break that, and they sue the hospital.
Yeah, it's very important that you know who you're talking to. I mean, if the right questions had been asked of him, who do you want to know and who do you don't want to know? Okay, that's important, because they will tell you.
Yeah, because the environment, you're sleeping every day in that room, like, the nurse was thinking, it's a
well, she thought it was okay to reveal the information. But one of the things you don't reveal is anything related to sexually transmitted infections, sexually related diseases, or pregnancy. Don't relate that. That's something that's only between the patient, you, and whatever the patient has designated.
It's in the really,
it's a fine line.
It's very dangerous, it's like, from one part to the other part is, the nurse had never intention to.
Yeah.
And of course, lawyers are there.
Yeah. Okay, so this tells you basically who you can do things with. And ideally, you should have oral or written consent from the patient. I mean, to reveal information. Depending upon how close you are to the patient and so on, the oral may be the case. But in the hospital, you know, there's too many other people involved, and so that consent should be written consent as to what can be revealed. Okay. And here it says about the issue of payment. If you are paying the patient's bills, then you do really have a right to know, except under the circumstances of the teenager in the state of Florida, at least, no, you don't have a right to know. And you have to protect that. I mean, otherwise you're not going to get these kids to talk to you. You're not going to find out what's going on. You're not going to be able to treat them. And they do get infections, and they do need to be treated. So you have to be able to get them their confidence. Okay. And the other is
Dr. Mary Jo,
yeah.
I have a question for you.
Yeah.
You said that as a doctor, you cannot reveal any infection, anything, any sexual stuff with the parents.
Yes.
What about if this one happened and then you have to prescribe a drug for that children and the parents is aware that drug is for that issue? So how this thing balance?
Well, you tell the patient, the mom, that you're giving her a prescription for an infection. You don't have to tell her necessarily what the infection is about. And you tell the child. I mean, I would always tell the teenager, no, listen, you're going to have this prescription. You need to be treated with this medication. You know, this is how your parents are going to start questioning what's going on. So maybe you would be the best person to tell them about this, because, you know, you're telling, I've got a problem here. I have to give you a medication. Your mother is going to have to pay for it. She's going to question it. So we have to have a discussion here about how you want me to go around this. And many times they'll come out and say, well, okay, you know. But I have had one who just said, no, I'll find some way to get that prescription myself.
Wow.
Mm-hmm. Right. Birth control pills are the big one, but they don't want them to know.
Okay, thank you.
And then there's the other situation in which the parent brings the kid in for contraception. You know, and now the new thing, the biggest thing that everybody, the world of reproductive health is pushing is what they call LARC. It's an intrauterine contraceptive device that is long lasting. And obviously, once you put it in, you can leave it in for a very long period of time. And this is what they're trying to push for teenagers, to have LARC or the IUD or this implant, so that they don't have to go back and get the prescription filled. They don't have to worry about missing the pills. It's all about letting them have sex as much as they want without the risk of pregnancy. So that's a big thing today. I mean, and it's just being pushed. It's a little bit expensive, but after you do this for about a year or 2 years, the cost becomes the same as the cost of a year or two of birth control pills. So it's not about stopping them. It's not about discussing them. I mean, it's very difficult. Believe me, I'm sure you all know this. Once you've had sex, to get them to go stop, to be celibate again, that's really takes time, really takes education, and really takes self-control. And you know, a lot of people don't know what self-control is all about. They haven't a clue. Mm-hmm. So that's the kind of society we live in, and it's a society we have to try and work in and work out. And this, by the way, this one, you know, I'm thinking about that nurse that you were talking about. That was not good judgment on her part, of course. But there are times that you have to use your own judgment.
There was something fast, you know?
There are times you have to use your own judgment about what you say.
Like, it's nobody wants to try to get information from you. You're just talking like a familiar conversation. Oh yeah, take this medication, yeah, here. Just come out.
Yeah, I mean, it would have been better if she said something like, because of her infection. I mean, obviously he must have known she was in the hospital for an infection. The word disease has a different implication in the world. It's disease means you has an STD. That's what they would think. And if you just use the term infection, it doesn't say that. It doesn't say what kind of an infection it is. I can remember having when I was a medical student, having a patient in ER who had pelvic inflammatory disease, sick. Oh my God. And it was gonorrhea. And boy, her husband was begging me not to tell her. Please don't tell her, she's going to know that it came from me, da, 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 da. I said, listen, it's her body. I have to treat her. I have to tell her what I'm treating her for. He said, well, just tell her you're having an infection. I said, yeah, no, she's going to ask me the next question. What did it come from? Of course I have to tell her. And he tried. I mean, my heart broke for him. But at the same time, she has the right to know. Okay, and he said, I can tell you it was the only time. I said, I have to tell him. And I felt so sorry for him. I really did. But he said it was his only time. Was it? I don't know. Okay. Now, the other thing you need to know about patients is that no matter what you do, no matter how hard you work with them, no matter how much discussion you have, some are wonderful, some are perfectly terrific about taking medications and doing exactly what you said. There is a large percentage who do their own thing, okay? Some of them will take the medicine for a week, even if it's a lifelong medication. Let's say a diabetic. Some of them will take it and not take it, and take it and not take it. And it really means, sometimes you feel like, okay, I really didn't sit and get what the patient really wanted from me, what the patient really understood, the patient's commitment, okay, to follow through. Adherence is a problem. And it doesn't matter what you're talking about adherence to. Whether it's medication, whether it's doctor's visits, whether it's follow-up testing, adherence is a problem. And when a patient doesn't feel sick, then why do I have to do this? If a patient has hypertension, I don't feel sick. Even though the blood pressure is 210 over 120, I don't feel sick. So they'll take the pill for a week. Okay? So these are big issues, and that's why it really becomes important to keep ongoing contact, which isn't done. Ongoing contact with patients who have issues. You really have to try to get them back, follow up with them. If they're not taking the medicine, why they're not taking the medicine? Is it they can't pay for it? Is it they don't like what it does to them? Is it they don't like the regimentation? Is it they don't want to accept the diagnosis? Is they don't believe you? Is it family issues? Is it too much trouble? Is it, I really don't care. I just don't want to do it. Period. End of story. So if I'm going to die of a stroke, I'm going to die of a stroke. And you can't do anything about that. But compliance is, and you really have to work at just trying to get them to be compliant. And these are some of the things that we have to think about in terms of compliance. Okay? And if you haven't had this discussion with a patient about, I'm going to give you this medication and this is the reason why you have to take it, and you have to take it at this time, and you have to do it this way, okay? And so if you miss a pill, okay, go ahead and take it right away, but try not to do that, and get there. Now, are you willing to do this? Yes. Walk out of the office. Okay? And we saw that a lot with AIDS. Oh, my goodness. Hypertension is a big one, too. Don't take the pills. And then there are others who, they couldn't be more adherent, they couldn't be more reliable, they couldn't be more perfect patients. But we are individuals. Just as the physician is an individual, the patient is an individual, and we have to let patients do what they want to do after you've done everything you can to try to make them understand. Okay, now what about the patient who doesn't do anything but remains in your office? What do you do? Okay, won't do what you say, and then you try to refer them to somebody else. Maybe you'd like to see, no, I don't want to see anybody else but you. Well, then we would really like you to do this. I'm not going to do it. Okay, why are you not going to do it? I don't like it. Okay, can we come up with something else? No, I'm not going to do anything else. But they'll keep coming back, and you have to be very careful about documenting this because you are the provider, and that patient's not going anywhere else. It's the same thing with a disruptive patient. There are patients who every time they come, they disrupt the whole place. Okay, so you try to get that, and they're not going anywhere else.
okay? No matter what you do, they won't go anywhere else, okay? Many of those have mental illness. So what do? You have to schedule them at the end of the day. You're exhausted, you know, and you really don't have the patience to deal with them, but you can't have them coming in the office and destroying the whole set of office hours, okay? But they're there. And really, those patients are the ones who do have mental illness, mental issues, and you try to get them in care too, you know, but again, they're the ones that can be the least compliant, the most difficult, or the patient who, I'm laughing now. There was this patient I had many years ago, and she was a diabetic. I'm going to stop. She was a diabetic. She had 3 previous cesarean sections. She was not compliant about her medication, no matter what I would tell her about the baby and how it was going to impact on the baby, not compliant. And then she suddenly announces to me, oh, and by the way, I'm not going to have a cesarean section. Oh? Meantime, this baby is already at 8 months, well over 10 pounds. I said, oh? She says, no, I'm not going to have a cesarean section. And of course, now that by this time, everybody knows about her in the group that we're working with. Everybody knows her. You got to get rid of her. I said, no, I can't get rid of her. I mean, at least she comes for care. You got to get rid of her, Mary Jo. You got to get rid of her. I said, no, we'll just work with her, work with her, work with her. Sure enough, she came in labor. Now the baby estimated fetal weight 13 pounds. Thank God I was there. Now estimated 13 pounds. I'm not having a cesarean section. So I said, okay. So I said, get the OR ready, get everything done, you know, get the blood. What are you getting my blood for? I said, because we have to know your blood type. And we by law have to screen you because we have to have blood available even if you don't want a cesarean section. You know, you could bleed after this baby's born and you rupture your uterus and the baby's dead and you're dying too. And she looked at me. You never told me that. I said, yes, I did. I've told you that on every single visit. Every single visit I've told you this. I'm not having a cesarean section. So she's in labor and of course nothing's moving. And finally I said, do you want the baby to die? She said, no. I said, then we have to do a cesarean section. Because if we don't do a cesarean section, the baby can't come out from below. You're too small. You already know this, okay? Baby can't come out from below. And look at the baby's heartbeat. Every once in a while, it's not doing so good. Meantime, it was fine. Every once in a while, it's not doing so good. Do you see that? Yeah. I said, and what if you rupture your uterus? That baby's going to be in your belly. I have to have that baby out in 5 minutes. I don't know if I can move you to the OR in 5 minutes. In fact, maybe I should take you back to the OR now so you're on the table. Finally, she said, all right, I'll do the cesarean section. I mean, but you couldn't walk away from her, okay? How could you walk away from something like that? Nobody else is going to deal with her. Nobody else is going to have the patience with her. You know, at this point, nobody wanted any part of her. Thank God we did the cesarean section because the scar was so thin that you could see the baby. And the baby was 15 pounds, not 13 pounds, 15 pounds. But you know, sometimes people don't think. They don't think straight. They don't think clear. She was afraid. I mean, that's what it was all about. She was afraid. Mm-hmm. And I mean, she knew I recognized that she was afraid. But the only way I could bring it up to her was, you want these things to happen? Okay. No, maybe it wasn't the right thing to do, but anyway, she had a cesarean section. Okay, now when it comes to the religious issues and religious objections, just like we have our objections, okay? We don't want an abortion, even though everybody says so. We don't want a sterilization. We don't want contraception. Do you want somebody to be in the operating room and tie your tubes and you don't know about it? No. You wouldn't want that to happen. That you didn't consent, but they thought it was the best for you, and so they tie your tubes anyway? Well, I've seen that happen with Jehovah's Witnesses. Refuse blood, okay? And they say, okay, we'll do the surgery. As soon as the anesthesia's in, put up the blood. What's wrong? Now, I didn't really understand that very well at all until I had to take care of an American Indian. I was telling Father this, American Indian, Jehovah's Witness, who had leukemia, and she was pregnant. And she had a hemoglobin of 4. She was in the hospital with a fever, like 300, 304, had a bad ear infection. Her hemoglobin, I said, was 4, and I wanted to transfuse her because I felt that if she got blood, then she would better oxygen carrying capacity to the baby because of the fever. The baby's oxygen levels are going to be affected. And so we had this whole discussion. She said, let me tell you something. She said, no. She said, let me tell you something. You want me to take this blood, but if I agree to take that blood, I am condemning myself to hell. I said, okay, we won't take the blood. We won't give you the blood. Because I thought, no, I can't live with that. I really can't live with that. If you take that blood, you're going to think you're going to go to hell. Now she comes in to have the baby, and her hemoglobin's back down to 4 again. It did went up to 6 with on iron and so on. Now it's back down to 4 again. Now I need a team that's going to willing to operate on her, anesthesia-wise, and not give the blood. So we finally did get a group together who was willing to do this. She had the surgery. She coded on the table. We got her back, and she went home with her baby and lived another 6 months. So it shows you that just because we think everybody's hemoglobin has to be 10 to operate on them, doesn't necessarily have to be so. It also shows you that as physicians, you know, with all of our understanding about medical legal issues, this is a time when you really have a good relationship with the patient, the family, and the church people, and they know, okay? And I would feel worse if I found out that somebody behind my back put blood up. I would feel like maybe I condemned her to hell. You know? So these are the kinds of things that you have to deal with. And the kinds of
JW, what did that mean?
Jehovah's Witness, sorry.
I'm sorry, what?
Jehovah's Witness. They don't take blood. Okay. Okay, this is again about religious objections, and I think you can read that. And we talked about the disruptive patients. You have to know mandatory reporting laws of the state because you are required as a physician to report according to the state law, like domestic abuse, violence, depending upon what your state laws say. As a physician, you have to report them. But you should tell the patient first. So the patient is aware. And if it's something that could affect what might happen with the patient, she can make preparations for an alternative way of managing herself. When I was a resident, we had a law in the state of Pennsylvania that we had to report anybody who came in who had an abortion. This was way back. We never did. We never did. We had an agreement among ourselves that we weren't going to do this, okay? Regardless of the state law, we were not going to do it. Because it just, you know, the patient was a victim too, okay? The abortionist, yeah, but the patient was a victim too. And we just didn't want to deal with that. So we never did that. So there are times when we don't follow the law. And court orders, getting court orders puts the physician in a very adversarial role, okay? And when you get a court order to do a procedure that the patient does not want, that the patient has refused. For example, a court order to do an intrauterine transfusion, a woman is a Jehovah's Witness, her baby is Rh negative sensitized, and you have to give the baby blood. And you have to do it, the only way you can do that in order to keep the baby alive in utero is to do an intrauterine transfusion. That becomes an issue of a minor. The minor is not a Jehovah's Witness, okay? A Jehovah's Witness is not a Jehovah's Witness until they declare that for themselves, and that's usually not until their teen years. And so in that situation, you might have to get a court order, especially when you cannot get the family or the church group to agree to let her have that transfusion. Then you have to go to court. Now you are in an adversarial role because you're forcing her to do something that she does not want to do. So you're really, it's what you call, what do you call that when you abuse somebody? No, it's really abuse. It's really abusing the patient. You know, it's not the word I want to use. Huh? It's more than coercion. It's a law. You're attacking the patient. What are you doing? You're attacking, huh?
Harassing her?
More than harassing.
Violence, abuse.
It's really a violence. It's abuse. You know, it's the wrong thing because you're really violating the patient. That's really what you're doing, violating the patient. But it's the one, you know, sometimes it's the only route you can go, okay?
So the hospital get court orders in the case for these people, the JW, the mom is in risk and she doesn't want to blood. Like,
The mom is not at risk here, the baby
no,
is.
yeah, I know, this is the case. In the case the mom's in risk and she doesn't.
Oh, she doesn't want blood and she refuses it?
Yes.
No, you don't have to go for a court order.
So she can die after that.
Mhm. Yeah, I mean, as long as we're talking about a situation like, for example, the Indian lady. I mean, she was refusing blood.
That's so I was outside trying to.
No. Wouldn't even consider it. She has a right to refuse, and I have to respect her wishes. There may be situations in which that might not be the case, but you know,
So
I think
actually-
most of the time it is.
Actually, at this time, that's happening in the hospital.
Yeah.
All the blood in the JW.
Mhm. Yep. I didn't get the hospital involved because I know if I did, that's what they go for the court order, and I didn't do that.
So you have to documentation of that?
Yeah, it's documented on the chart, but I didn't bother to get hospital administration involved, which I probably should have, but I didn't, because I knew that they would tell me that we had to do it. We had to get a court order, and I wasn't going to do that. I mean, what this woman told me, no way. And my group that I was working with said, okay, if that's what she wants, that's what she wants. So we didn't bother to involve the hospital.
That's interesting.
Okay, and this is the slide that has the references for you that you can go ahead and look up. If you want me, just jot your name down and I'll email them to you. I have all three of them in my, and the last one actually is an editorial, which discusses an article in the journal. The editorial is excellent though. Yes.
You said the patient died 6 months later?
She did, yes. Of her leukemia. Yeah, she had a very severe leukemia. That's why her hemoglobin was so low, was her leukemia. But she had 6 months with her baby.
Yes.
That was the big thing. Right. Okay, any questions?
Yeah, what is Ed on? What does it mean?
And others. So like Emmanuel he's the first author, and then et al. Means and other authors, and the other names are and others. It's et al's and others.
Ah,
Okay. So that he's the primary author, and then there are other authors besides. That's a way we have of doing that. I mean, I could have listed them all out, but why do that when I can get away with this? Okay, guys, any questions? Ed, Guardia?
Healthcare, I'm
What?
not, what's talking about
I'm good.
Okay, this is Annuals of Family Practice. That's the journal. Annuals of Family Practice.
Oh, in the middle, analysis for
Healthcare Analysis.
analysis.
Yeah, that's the abbreviation for the journal.
Oh, okay.
Healthcare Analysis. And JAMA is the Journal of the American Medical Association.
Oh, okay.
Okay, but if you guys want these, let me give you my email, and then you can email me, and I will get them to you. It's
Okay.
M.O'Sullivan at med, that's med, .miami.edu. Okay?
Sounds good. Thanks.
So get it to me today because I'm leaving the country tomorrow, so I'd like to get it out to you today. Otherwise, forget it. I might not remember when I come back.
Thank you.
Okay, you're welcome. Huh?
Thank you.
Yeah, we're done.
stop the recording.
Guardia, your husband knows I'm leaving. I left him a message, okay? She's off.
Thank you for all you did.
Never mind, don't talk about it.